Good morning. I'm Ahmed Mokhtar, a lecturer of Cardiology and Angiology at Alexandria University and specialized in the cardiac electrophysiology. I'm going to speak today about atrial fibrillation. You all know that atrial fibrillation is the most common form of sustained cardiac rhythm disorder, and its importance comes from its burden on the healthcare system. It represents a major problem for the healthcare system due to a very high financial burden on these systems, plus repeated hospitalization and repeated admission either for atrial fibrillation episodes or for worsening heart failure, or stroke, and so on. Atrial fibrillation is a disease of aging, increasing its frequency with increasing each decade of age. So it's common among elderly, but it still occurs in the younger people. And the problem of atrial fibrillation is its propensity to develop stroke, which is increased risk of stroke up to twofold increased in heart failure, developing heart failure, and also increased total cardiovascular mortality. When we look about atrial fibrillation pathophysiology, it's very complex and multifactorial. We have a lot of cardiac and extracardiac causes that could predispose the patient to develop heart failure, including advancing age, hypertension, coronary artery disease, diabetes, thyroid dysfunction, and cardiopulmonary embolisms, and COPD, and obesity for sure. The drug effects, all these causes could lead to what's called structural changes in the left atrium, leading to replacement of these muscles by fibrous tissues, and these fibrous circuits increase the probability of sustaining atrial fibrillation when we have a precursor. But usually the precursor of these atrial fibrillation episodes is coming from the pulmonary veins. We have what's called the pulmonary vein potentials that cause premature beats. In this structurally modeled heart could lead to the development of atrial fibrillation. We have different types of atrial fibrillation. We have what's called the newly diagnosed atrial fibrillation when we diagnose it for the first time, and we have a paroxysmal type, which is the atrial fibrillation lasting less than 7 days, either terminated spontaneously or terminated by electrical cardioversion. We have what's called resistant atrial fibrillation when these episodes lasting more than 7 days, and if it lasts more than 1 year, we call it long-lasting persistent atrial fibrillation. The last form is the permanent atrial fibrillation, when the doctor and the patient decide not to adopt a rhythm control strategy and only to develop the rate control strategy. For sure, we diagnose atrial fibrillation just by examination. When you find a irregular rhythm, you order ECG, and you could diagnose atrial fibrillation as a chotic rhythm easily by ECG. But sometimes when the patient have just paroxysmal attacks, you could need more than ECG. We could do Holter or more sustained recording system to diagnose the episodes according to its frequency. And you need to assess the underlying cardiac function using echocardiography to assess the systolic function, the presence or absence of valvular diseases, and also to assess the left atrial size and exclude the presence of appendage thrombosis, which is the main source of stroke in these patients. After you diagnose atrial fibrillation and you are faced with the patient, you have to assess the hemodynamics. If this patient is hemodynamically stable or unstable. Because if you have any hemodynamic instability, hypotension, pulmonary congestion, severe symptoms, you need to admit your patient and to put a plan to cardiovert this patient, either electrical cardioversion using the DC shock or pharmacological with drugs. This step for sure should be done after we exclude the presence of appendage thrombosis by transesophageal echo, or if the episode is less than 48 hours. If our patient is hemodynamically stable, so we have to think what is the risk of stroke in this patient. And this is usually done using scores like the shared VASC score, which is the most popular form, we assert SHAD VASC stands for congestive heart failure, hypertension, aging, diabetes, previous stroke or TIA, and vascular disease, and age less than 65 and female sex. If our patient have a SHAD VASC score of 2 or more, this mandates long-term oral anticoagulation. This is, if your patient is just 1, it may be considered to give oral anticoagulant. Less than 1, no need for oral anticoagulant, and also no need for oral antiplatelet drugs. These scores stand only for non-valvular AF, because we all know that valvular AF is an indication for long-term oral anticoagulant in the form of vitamin K antagonist till now. If our patient have any contraindication to receive long-term anticoagulation, so we could do what's called appendage exclusion or left atrial appendage occlusion, which could be done either percutaneous or could be done also surgical. After we assess the stroke risk, we have to choose which plan we will treat the patient, either to adopt a rate control or rhythm control strategy. Both the strategies are equal regarding cardiovascular outcomes and mortality, but some difference regarding the quality of life. The rate control strategy is more suitable for patients with permanent atrial fibrillation and those with a long history of atrial fibrillation, or those who are resistant to the rhythm control and having a lot of recurrence despite antiarrhythmic drugs. So in these cases, we choose to give the patient drugs like beta blockers, calcium channel blockers, or digoxin to slow the ventricular response. Or in refractory cases, we could do what's called AV nodal ablation, and this might need a backup pacing, so it's what's called a latent pace strategy. In patients in whom we choose the rhythm control strategy, we have either to give a long-term antiarrhythmic drugs or to do ablation. Antiarrhythmic drugs should be tried first using either class 1 or class 3 antiarrhythmic drugs, and the choice of antiarrhythmic drugs depends on the safety first. We have to choose the more safe antiarrhythmic drug, despite it might be less potent, rather than starting with a more potent drug with also a higher risk of side effects. We all know that some of these drugs have what's called a pro-arrhythmic effects, which means it could predispose more arrhythmias rather than treating these arrhythmias. If our patient is not controlled with 1 or 2 antiarrhythmic drugs after at least 3 months, it could be a candidate for ablation. The patient who is candidate for the ablation is young patient with paroxysmal attacks that is not responsive to antiarrhythmic drugs despite being on this treatment for at least 3 months, and in whom we don't have a marked left atrial dilatation. In this patient, we could do what's called pulmonary vein isolation, aiming to create a fibrous barrier between these pulmonary veins and the left atrium. This could be done either using radiofrequency ablation under the coverage of the 3D anatomical mapping system like CART or NAVIX or some other forms, or it could be done using the cryo balloon, in whom we use nitric oxide gas to create an ice crystals around these pulmonary veins. The choice of the technique depends on the local experience and the availability and the cost. All of these management strategies is present in our lab in Alexandria University and in our center in the ICC, and we hope you I could quickly wrap up atrial fibrillation and highlighted the important point of this atrial fibrillation. And thank you, and see you in the next episode.